Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Listen carefully. When we speak about chronic fatigue, do not reduce it to laziness, weakness, or a lack of character. Do not say, just try harder. Do not say, push through. That advice can be medically careless. Chronic fatigue, especially when it resembles myalgic encephalomyelitis/chronic fatigue syndrome, is not ordinary tiredness. It can involve profound exhaustion, post-exertional malaise, unrefreshing sleep, cognitive slowing, pain, dizziness, immune-like flares, and a level of functional decline that can change a person's identity, work, relationships, and future planning. So why speak about motivation at all? Because motivation, when understood correctly, is not emotional hype. It is not forcing the body to perform beyond its biological limit. It is a clinical tool for direction, pacing, decision-making, self-management, and hope. Use it as a compass, not as a whip. Use it to organize energy, not to deny symptoms. Use it to protect the patient from the two extremes that often cause harm: total surrender on one side and reckless overexertion on the other. Ask yourself, why do many people with chronic fatigue crash after doing something that once felt normal? Why can a simple errand, a conversation, a shower, or a work email trigger a setback that lasts hours, days, or longer? The CDC describes post-exertional malaise as a worsening of symptoms after physical or mental activity, and it emphasizes activity management within an individual energy limit. NICE guidance also centers care around individualized energy management rather than fixed increases in activity. That matters deeply because the right kind of motivation must respect the body's threshold. It must say, move wisely, not move blindly. Now command your thinking to become more precise. Motivation is not the cure. Motivation is the structure that helps a person participate in care, notice patterns, prevent crashes, ask for help, maintain dignity, and keep meaningful life goals alive within changing limits. Why is that beneficial? Because chronic fatigue often steals rhythm. It disrupts sleep, work, social contact, confidence, and planning. Motivation helps rebuild rhythm in small, deliberate units. And how does it work? It works by transforming the question from how do I get my old life back immediately into what is the next medically respectful action I can take today? That shift is powerful. First, understand the body. Do not motivate a person with chronic fatigue before you understand the terrain. Tell the patient, track your symptoms, write down sleep, activity, food, stress, screen time, standing time, heart rate if useful, and delayed crashes. Why? Because chronic fatigue often hides its cause and effect pattern. The cost of an activity may not appear immediately. A person may feel acceptable during the task, then deteriorate later. That delayed penalty is one reason the illness can feel so hard to manage. The 2015 Institute of Medicine report, now associated with the National Academy of Medicine, described ME/CFS as a serious, chronic, complex systemic illness marked by reduced function, post-exertional malaise, unrefreshing sleep, cognitive problems, and often orthostatic intolerance. Notice the language: systemic, not imaginary, not merely emotional, not a personality flaw. So motivate the person to behave like a careful investigator. Say, observe, record, compare, adjust. Do not guess every day from scratch. Build a map. Why is this form of motivation effective? Because it turns helplessness into feedback. A patient may not control the entire illness, but they can often identify triggers. Standing too long, intense conversation, emotional conflict, heat, poor sleep, skipping meals, sensory overload, or doing several small tasks back to back. How do you use that information? Create an energy budget. Put demanding tasks earlier if mornings are better. Split one large task into 4 smaller actions. Rest before symptoms shout. Stop before the body starts negotiating with pain. Say this clearly. Rest is not failure. Rest is treatment behavior. Second, use motivation to protect the energy envelope. The CDC describes staying within personal activity limits as remaining within the energy envelope. NICE defines energy management as a self-management strategy that helps a person stay within their energy limit, with professional support when available. This is not passive living, it is active control. It is the patient learning how not to spend tomorrow's biology on today's pressure. Ask, why do people overdo it? Often because they are afraid of disappointing others. They want to prove they are still capable. They miss who they were. They may feel guilty resting while dishes, work, children, parents, bills, and messages are waiting. So motivation must be redirected. Do not motivate the person to impress others. Motivate the person to preserve function. Give this command: choose the goal that protects your next 48 hours, not the goal that only looks good for the next 20 minutes. How can this be practiced? Use a traffic light method. Green activities are usually safe. Brushing teeth while seated, 5 minutes of quiet stretching if tolerated, a short call, basic hygiene, a simple meal. Yellow activities are possible but costly. Grocery shopping, long screens, emotional meetings, driving, standing in line. Red activities predict a crash. Intense exercise, full social days, sleep loss, multitasking, long travel. Now instruct the patient. Do not remove all yellow forever, but do not stack yellow activities. Never stack red activities unless there is no choice and recovery time is protected. Third, understand motivation as self-efficacy. In chronic illness care, self-efficacy means the belief, built through experience, that I can take the next useful action. It is quieter than confidence and more durable than excitement. Research on fatigue self-management has explored how perceived self-efficacy connects with fatigue management, and broader chronic disease literature repeatedly shows that self-management improves when patients feel capable, supported, and involved in decisions. Why does this matter in chronic fatigue? Because repeated crashes can train the brain to expect defeat. A patient may begin to think, "Nothing I do matters." That thought is emotionally understandable but clinically dangerous. It can reduce symptom tracking, sleep discipline, nutrition planning, hydration, medication adherence, medical follow-up, and boundary setting. So give the patient wins that are small enough to be real. Do not prescribe heroic goals. Prescribe believable goals. Say, today, your goal is not to clean the house. Your goal is to sit while preparing breakfast. Your goal is not to exercise for 30 minutes. Your goal is to notice whether 2 minutes of gentle movement is tolerated without a next day penalty. Your goal is not to answer every message. Your goal is to send one clear sentence: I am conserving energy today. I will reply when I can. How does that help? Each completed micro goal teaches the nervous system, the mind, and the family environment that the patient still has agency. Agency is medicine adjacent. It does not replace medical care, but it changes the way care is used. Fourth, distinguish wise motivation from harmful pressure. This is essential. Older approaches sometimes emphasized graded increases in activity. Today, major guidance has moved away from fixed incremental exercise programs for ME/CFS, especially when post-exertional malaise is present. NICE specifically warns against programs based on fixed increases in physical activity or exercise. Why? Because the body's response is not always linear. More effort does not automatically create more capacity. For some patients, more effort creates a deeper crash. So say it plainly. Do not weaponize motivation. How should motivation behave instead? It should ask, what is the safest next step? What does the body allow today? What pattern appeared last week? What support would reduce energy cost? What can be simplified? What can be delegated? What can be done seated, shorter, slower, quieter, or later? This is where motivation becomes highly practical. Tell the patient, reduce friction. Keep a chair in the bathroom. Prepare medications and water near the bed. Use grocery delivery if possible. Batch decisions, not tasks. Wear compression garments if orthostatic symptoms are present and a clinician agrees. Discuss salt, fluids, sleep disorders, pain control, migraine, allergies, POTS-like symptoms, anemia, thyroid disease, autoimmune disease, medication effects, depression, and sleep apnea with a qualified clinician. Do not assume every symptom is just fatigue. Investigate appropriately. Fifth, use values-based motivation. Ask, why should a patient keep going when progress is slow? Because motivation rooted only in symptom improvement can collapse on bad days, but motivation rooted in values can survive fluctuation. Values sound like this: I want to remain connected to my children. I want to protect my dignity. I want to keep learning. I want to reduce crashes so I can attend one meaningful event. I want to communicate clearly with my doctor. I want my life to remain mine, even if it is smaller right now. Self-determination theory, a major framework in health behavior change, emphasizes autonomy, competence, and connection. Meta-analytic work has found that autonomy supportive approaches are linked with better health behavior engagement. In plain language, people follow care plans better when they understand the reason, have choice, feel capable, and are not treated like disobedient machines. So command this: do not motivate by shame, motivate by choice. Ask the patient what matters enough to protect your energy for. Then design the day around that answer. If the value is family, maybe the goal is not cooking a full dinner. It is sitting at the table for 10 peaceful minutes. If the value is work, maybe the goal is not returning full-time immediately. It is one carefully timed task with rest before and after. If the value is independence, maybe the goal is using assistive tools without apology. How is that effective? It reduces the emotional tax of constant self-justification. It also makes pacing feel less like loss and more like strategy. Sixth, use social motivation. Chronic fatigue can isolate people in a very specific way. They may look well enough to be doubted, yet feel too unwell to participate. This gap can wound relationships, so give families commands too. Believe first. Ask before advising. Lower the noise. Offer specific help. Do not say, "Let me know if you need anything," and disappear. Say, "I can bring food on Tuesday," or "I can handle one phone call," or "I can sit quietly with you for 20 minutes. Why does this matter medically? Because social stress consumes energy. Conflict, explanation, guilt, and disbelief are not neutral. They require cognitive and emotional work. For a patient already rationing energy, being believed can reduce the burden. How can the patient use motivation here? Prepare scripts. Say, "I am not avoiding life, I am preventing a crash." Say, "If I leave early, that is my treatment plan, not rejection." Say, "Please invite me, but allow me to decline without interrogation." Say, "I need quiet support more than advice today." Seventh, make motivation measurable. Do not wait to feel inspired. Create a system. Use a daily scale from 0 to 10 for energy, pain, sleep quality, brain fog, and standing tolerance. Mark crashes. Mark recovery time. Mark what helped. Then review every week. Why? Because memory becomes unreliable when fatigue and brain fog are intense. A written record can reveal what the mind misses. How do you keep the system sustainable? Make it short. 1 minute. 5 numbers. 1 sentence. That is enough. Do not turn self-monitoring into another exhausting job. Then use the data. If 3 social events cause a crash, reduce to 1. If showering drains the morning, sit down, shorten it, lower the heat, or move it to another time. If screen use worsens brain fog, use audio, larger text, breaks, or scheduled silence. If standing triggers dizziness, discuss orthostatic intolerance with a clinician. Motivation says, adjust the environment before blaming the person. Eighth, protect hope from fantasy. Hope is not pretending the illness is easy. Hope is believing that careful action still has meaning. Some patients improve, some stabilize, some fluctuate, some remain severely limited and need substantial support. Speak honestly. Do not promise a miracle, but do not remove possibility either. Why is motivation beneficial here? Because chronic fatigue often creates a long uncertainty. The absence of a simple cure can make people vulnerable to despair or to expensive promises. Motivation helps them ask better questions. What is the evidence? What is the risk? What does my clinician think? What outcome will I measure? What will I stop if it worsens me? Is this helping or am I chasing? How do you apply that today? Pick one behavior that protects energy, one behavior that supports the body, and one behavior that preserves meaning. For example, rest before symptoms intensify, prepare hydration and food, and send one warm message to someone safe. That is not a small life. That is a disciplined life under difficult conditions. So bring all of this together. Chronic fatigue asks for respect. Motivation gives direction. Chronic fatigue imposes limits. Motivation helps identify them, honor them, and work within them. Chronic fatigue can shrink the world. Motivation keeps the person from disappearing inside that shrinkage. Do not use motivation to force a sick body into performance. Use it to create wise pacing, symptom awareness, self-efficacy, medical follow-through, boundaries, supportive relationships, and values-based living. Ask why until the goal becomes meaningful. Ask how until the plan becomes safe. Then act in smaller steps than pride wants, with more consistency than fear expects. Say this to anyone living with chronic fatigue. Your worth is not measured by productivity. Your discipline may be invisible, but it is real. Resting before a crash is discipline. Saying no is discipline. Tracking symptoms is discipline. Asking for help is discipline. Choosing one meaningful action and protecting tomorrow's body is discipline. And say this to families, clinicians, and communities. Listen closely. Believe the patient. Support pacing. Celebrate careful progress. Remove pressure where you can. The goal is not to push someone back into life at any cost. The goal is to help them remain safely connected to life, one protected unit of energy at a time. Thank you for being here and take good care of one another. We are learning together like a family around the same table. See you in the next topic.